according to Monique, means that the hat on the head means you're lying. I've never heard that, but that's the origin of cap. I'm about to look this up. I'm going to look.
Tendencies to be less open-minded.
Which is crazy because that's literally one of the 3 spiritual principles that we have to follow.
Yeah.
We have to have open. Yeah, we have to be open-minded.
All right, Barbie, can you tell us a little about yourself?
My name is Barbie, and I am a facility maintenance manager at McShin. I've been here a year, and when I came back, the place was a mess, so I knew I was missed.
It's beyond my wildest imagination.
It's getting deep in here now.
It's incredible, man.
To have the rainbow without going through the rain. And I love it.
Me too.
Good.
Yeah.
That's good. And applying the recovery, I thought about it for a second.
Good afternoon, VA. That's my new thing here on here. Good. Remember that movie, Good Morning Vietnam? All right, everybody. Good afternoon. We got a great podcast scheduled for today. We're gonna have some good conversations, some good talk around some stuff. So I'm looking forward to this. We got John Shinholser gonna be our co-host, special guest, special co-host. John Shinholser. He wants to start. He just was talking. He's getting ready to start his own little thing, y'all. So tune into that. His own.
Oh yeah, that's gonna be big time, man. I'll be up there with Joe Rogan.
Joe Rogan. He's a beast. And we got a special guest, one of our board members, Dr. Popovich. Did I say that right?
It's Popovich.
Popovich. Is it not Polish, is it?
I think it's pretty common all over Eastern Europe.
Okay.
Yeah.
Because mine's Polish. It's Wysocki, but it's supposed to be pronounced Wysocki. And I go with the Wysocki route. So.
I like Wysocki better. Actually,
He said,
I'm glad you clarified.
I done messed up now. All right, everybody tuning in. So shout out to Steve. He's the Wizard of Oz, the man behind the scene over there making things happen.
Hey, Steve.
Hello, everybody.
All right. So real quick, before we get into the podcast, I do want to shout out 2 of our sponsors. So we have a recovery ambassador, Hype Counseling, who has sponsored our recovery. So I'm not going over all our events, but I do want to let y'all know our next upcoming event is Overdose Awareness. August 31st, Overdose Awareness Vigil, 6 p.m. It's from 6 to 8. It'll be here in our Memorial Garden, and something happened to the sound. No. All right, there you go. Here in our Memorial Garden at 2300 Dumbarton Road and our chapel. We got a couple people singing, some speakers. John, are you coming out to that one?
On the overdose awareness?
Yeah, that's 31st. Okay.
I think I'm going to be in Arkansas.
Oh, you're going back there?
Right.
Okay. Well, Doc, if you're around, check it out if you want to. It's a great event. There'll be a couple speakers and a couple, I think Monique was saying somebody's doing some spoken word. So it's a cool little event. Anybody out there listening, come check that out. That's our next event. All right, so I want to get into our podcast and what we got going on. I'm going to let John, everybody out there probably knows John, but I'm going to let him introduce himself. He's our co-host. He's our founder here of McShin, and then we have one of our board members here as well. They'll do a quick introduction, then we got some questions we want to get into.
Well, John Shinholser, co-founder, president emeritus of the McShin Foundation. Most important, an old-timer in recovery. I've been at this over 41 years, continuously.
41 freaking years, y'all. He just celebrated that, too, but a couple weeks ago, right?
Yeah, August 10th.
Yep, 41 years. A lot of knowledge, y'all, a lot of knowledge. And Doc?
My name's Stephen Popovich, and I'm an addiction medicine physician who practices here in the Richmond area. Actually, my background was in internal medicine or primary care for adults, but I was working with underserved populations kind of in East Richmond, and then at Daily Planet Health Services, which is a community health center in downtown Richmond. And it was kind of there that when the opioid crisis was taken off that I went headfirst into it, because we had a lot of patients in need and had opportunities to learn it. So I've been practicing full-time addiction medicine now for the last couple years, and got introduced to the McShin Foundation mostly through patients, because I had so many folks who had connected here for services, lived in a recovery house, and just saw the impact it was having on folks. So reached out to John and got to learn more, and one thing led to another, and now I'm here on this podcast.
What the doc don't know, I was stalking him for a couple of years, pre-selecting him for our board should the opportunity come. But I wasn't sure you'd get on it. But when you said, yeah, I got so excited, man. We're so glad to have you on our board. We appreciate the time and energy and effort you're putting into this. So thank you.
Yeah, I definitely concur with that. John, didn't we, Doc, you worked at Clean Slate at one time, right?
That's right. I was working there.
I just remember me and you, John. I don't know if you remember this. Me and you went. So Clean Slate had an office over on the South Side, and like we were trying to just find local addiction specialists and just build our resources. And we went down there. We went in there. I don't know if you remember. We were trying to find out who the doctor was. I don't know if you were working there at the time, because this was probably about 4 years ago.
It'd be a while back.
Yeah. You weren't there. Were you there 4 years ago?
I think that might have been before my time,
Okay.
but gosh, there's a rock star NP who was there at that time, and she's still a part of things there. So
Okay, cool. Well, you kind of, I'm really fortunate to be able to sit here with both of y'all, man. I don't tell John enough, how all the knowledge he's got. I love like picking his brain. Sometimes I pick his brain and it becomes a fight. He doesn't want to give me the information.
You start picking my ego sometimes. it fights back, man.
I challenge it, but I love it, man. John's got so much knowledge, and on the subjects we're going to talk about, he's got a really, really, really good institutional knowledge, because he's helped spearhead a lot of the things in the area. And Doc, I've been watching you from afar too, man. I really appreciate you being on the board, giving your input. We really need that here at McShin, so we're happy to have you. You kind of touched on this, but inside though, I'm curious, like what inside of you kind of sparked you to become that addiction specialist? Because you kind of talked about career wise, but was there anything specific, or was it just like it just fell in your lap and you just kind of rode with it?
I think within medicine, I could have done a lot of different things, things that mattered. I think I ended up in medicine because it was kind of this intersection between people and science, and I always had a brain for science. But within the realm of medicine, there's so many different areas, and primary care really stuck out to me early on because of the impact that I knew it had on communities. And then when I learned about addiction medicine and how underutilized the interventions are, I think it's even today with all the publicity and general awareness of it, it's about 2 out of every 10 people that have an opioid use disorder who actually connect to treatment. And there's just very few interventions as powerful as engagement with the medical system and the use of medications specifically, as far as saving lives and also helping people reach their goals in life and get their lives back. So that's why I'm there, because when I learned about it, the impact is just exceeds the tools that I had to help people in a primary care setting. Yeah, that's how I ended up in there.
John, when we were talking the other day, you were throwing out some of those statistics about how many people don't get reached.
Harm reduction.
Yeah.
I'm talking about that most of the people that need services will never engage or get it. That's why I was saying we need to do a better job engaging, reach that 85% that never gets engaged. We focus on the 10-15% that's seeking services, and we do a good job with that. But what about the rest of these folks? So that conversation was kind of centered around that.
Yeah, I remember that. And so, and that's kind of how medication assisted treatment works, right? It gets more people engaged. Is that what y'all would say?
Oh, I think it's a great entry engagement system of care, 100%. I mean, Doc. Well, I think.
Can you repeat the question here? Yeah. Help me understand where we're.
He's still on vacation.
Yeah.
So, does MAT work at getting people engaged in recovery? Is it a way to engage them, get them involved into recovery?
I think absolutely. People with substance use disorders are individuals first and foremost. There's not different people have different needs, and I think engaging with whatever it takes to engage in the healthcare system, whether it's a comprehensive harm reduction program. Shout out to my people at Health Brigade who do just a great job here locally. If that's the touch point, or if it's someone who's actually willing to walk into a medical office, or if it's someone who's has a friend or a peer and they hear about McShin or a similar organization, it's getting people through the door. It takes a lot of courage, so much courage for anyone to admit that they are dealing with a substance use disorder and reach out for help. And so whatever door they're willing to walk through, including the medical office, like one I work in, is just something to be celebrated when that person walks through the door. And, when you look at, for someone with an opioid use disorder, just the absolute misery of going through withdrawal, I think about it just like physical hell, psychological hell, just absolute despair. And for a lot of those folks, we can help get them through that period that's so terrifying if we'll just use medications appropriately. And also psychologically, just like letting them know they're not alone, that we're going to take it one step at a time with them, is just a really important approach. Because as you all know, there's so much shame and stigma, and people with substance use disorders just historically and even currently get treated so poorly. Imagine how disappointing that is to reach out for help and to be judged and to denied access to treatment.
So anybody that tunes into our podcast or happens to come across this and listens to this, if you don't know what MAT is, MAT is medication assisted treatment. There's a wide variety of different medications you can use. It could be anywhere from methadone, Suboxone, Vivitrol. There's a wide variety of different ones. I don't know if I'm missing some of them.
Well, those are brand names, but
what are so I don't. What other way do you call them though?
Here, let me touch on that. Actually, within my professional society, the American Society of Addiction Medicine, who I can't speak for, I'm a member, but I certainly can't speak for them. We've really actually tried to use the word medication for opioid use disorder, or MOUD, as opposed to medication-assisted treatment. And that is to reduce stigma, because medication-assisted treatment implies that universally that someone needs something else other than medication. And while we know that the vast majority of people do best with comprehensive services, there are people that will, on the full spectrum, that if they'll engage with just medical treatment, like, we can do that person a lot of good. And so rather than saying, hey, this is just a part of the treatment, we say, like, hey, for some patients, this might be all they're willing to walk in and receive, and we should embrace that, because we know we can reduce the number of people that will die if we'll give that person an entryway. So we use
what is
MOUD.
it again? MOUD?
Yeah.
So, okay. All right.
And that also plays a role in why 85% of people won't seek services right there, because
of the stigma?
Not only the stigma, but in their brain, they automatically think, oh, my God, I don't want to do what the country's been doing for the last 50 years. I have a problem with a specific substance. I need to get help with a specific substance. Now, I don't have a problem with these other substances, and our systems are geared toward, I'm going to say it, abstinence-based or inpatient treatment or whatever. So we got to make that some sort of inviting system of care to get these 85% of people at least engaged in some sort of education on what their particular problem is. So.
Yeah. I think that's a great point, John. As in, like, the education piece, because a lot of people, don't really know what. And you said MOUD.
MOUD. Yeah.
They don't really know exactly what it is, and there is that stigma, and there's that fear of being judged, that kind of thing. I have a question. I didn't prep you on this question, but I'm just curious on both y'all's kind of thoughts on this. So, if medication is provided for opiate use and substance use, it could be considered MOUD. What about if there's medication provided for mental health disorders? Is that considered MOUD as well?
Yeah, so there's only 3 medications that are FDA approved for the treatment of opioid use disorder, and those are the 3 where there's good evidence for. And those are naltrexone, which is a full opioid blocker, or an opioid receptor blocker. The brand name for that one, most commonly used, the injectable form, is Vivitrol, but it is available as a pill form over the counter, or excuse me, not over the counter. It's available as a generic pill form. And then there's buprenorphine, which is almost universally prescribed in a form that attaches it to naloxone. So it's buprenorphine naloxone, and most folks refer to that as the brand name Sublocade.
Yeah.
And then the last one is methadone, which of course is separately regulated because it does have it is a more dangerous medication than the other 2.
I got you. The only reason why I asked this, right, John and Doc, is because I've had participants come to me who were meth users, right? They were meth users, and they were like, I need, and they called it MAT. I need MAT, and my MAT is Adderall. I don't know if that's the brand name. I don't know the not brand name, but that's what they would say they would need it, and that's what they kind of justified that, saying that that's considered, to them, it's considered MAT.
Yeah. So it's a different receptor that methamphetamines and cocaine work on as opposed to opioids. It is also a huge problem, but most of medical care is really focused on alcohol, tobacco, and opioids because those are the things that medications have been proven most effective for. Actually, the head of psychiatry at VCU, whose name I'm just blanking on at the moment, is someone who's been exploring an intervention for stimulants most of his research career. And there's really never been proven to be a medication that helps. Adderall, whose generic name I'm actually blanking on at the moment, does work on the same receptor as amphetamines and cocaine. And so people do feel better when they're getting cravings for those and they use it, but it is not an approved treatment for the treatment of stimulant use disorder.
I do remember back in the 80s that, and I read a lot, I read the paper every day, but since the 80s, you've been hearing talk about medications for cocaine, for, we called it crank back then, crystal, whatever, but meth. So I think that's been a 50-year journey in medicine trying to find good alternatives to good, replacement therapy. So, Doc,
you got to do 5 push-ups and 10 jumping jacks because your phone went off. I've had a lot of participants, hit us with that, and kind of we tried to maneuver through that. So I just was curious, kind of what the thought on that was. So, speaking about the different medications that could be used, let's talk about Vivitrol for a little bit, because and I guess I hate, is that the name brand too? I don't know if is there something else that's called? Do I call it something else?
Yeah, you could call it intramuscular naltrexone, but the brand name does roll off the tongue a little easier. So.
Yeah, I mean that's really the only one I know. But
that's how they make money.
Yeah,
but
so I'm not supporting it. Anybody out there?
Yeah.
Sorry, it's not a commercial.
It's
not a commercial. It's not a commercial. But I'm curious. Yeah, right. I'm curious to get y'all's input on that, John. I know you've got a good, very opinionated view on Vivitrol.
Well, I think there's a couple angles here. One is that anytime you do a medication that, gives you thought, daily positive affirmation, hey, look, there's no sense in me doing this drug, my drug of choice, because I have this medication in me that's going to block it. So I think that's a hit right there. But to go a little deeper, as a 12-stepper that is sponsored, worked through the steps with thousands of addicts over the years. And I'm one of the few 12-steppers that I will sponsor people on medication. I've never said no to somebody as long as they follow my instructions. So I've sponsored, going back as far as 10 years ago, I started sponsoring these kids. And the ones that, to me, that stayed on that naltrexone the longest, they could reach that 3, 4, 5 year period of abstinence on other drugs. And if you can go 5 years, in a recovery lifestyle, abstinent of dangerous drugs, that gives you an 85% chance going the rest of your life pretty much trouble-free. And so I think there's a sweet spot there for the opiate addicts. If they can somehow make a jump from opiates to Vivitrol, engaged in connection to community, work some kind of program, give them a whole new purpose in life, they do great. The ones that I see that do it short term are quicker to go back to drug use.
Yeah, it's funny that you talked about, John, sponsoring guys. One of the few that did that. That came about with me, and I had to call my sponsor, and he was like, why would you not, sponsor these guys because they're on, and it made sense to me. I was
and
like,
that's something we need to change in the 12-step community. You know what I mean? So and go back 20 years ago, it wasn't favorable. People would frown on that, but. The more you grow spiritually, the more you realize, hey, look, these people are asking.
They need it. Yeah,
experience, you give it to them.
Yeah,
And then just leave it up to them how it ends. But
yeah, exactly.
I'm a big fan of Vivitrol, absolutely. And I think Vivitrol, to me, is better than the risk of methadone or other potentially harmful or abusable replacement drugs. And buprenorphine does have a high rate of abuse and diversion, and it keeps in some addicts' mind, it keeps them in the game in their head. Not everybody comes along as 100% compliant. If you're a good patient, if you comply, you'll get a good result. Well, the population we deal with is very manipulative. And they don't always tell the truth, and so it's a cleaner, to me, it's a cleaner recovery path for very serious people that want to follow suggestions and instructions and direction. But that doesn't, I've sponsored lots of people on buprenorphine too, and they seem to do well too until they don't. Yeah. So
what about you, Doc? What's your thoughts on the naltrexone?
I'll just go back to what I said earlier, that each patient with a substance use disorder is really an individual, and they have individual risk factors, and not everyone's opioid use disorder is the same. And John, I think you actually used a word that is very interesting. You used the word jump. If someone can make the jump from using opioids to naltrexone, that is a very positive thing.
That's a difficult spot right there, though, man.
Yeah, and it is. I think jump is a good word because earlier I was describing what does it mean to go through withdrawal from opioids, and it's different for different people. I have met some people that it's not a big deal, folks that have not been using long or whatever, their brain chemistry is different. But the vast majority of people, that is a big jump. That's a lot for a person's brainstem, where this activity is going through, where cravings live, just the psychological pain of going through withdrawal. And because naltrexone's 100% opioid mu receptor blocker, that's why fewer patients use that medication, because it is very difficult for them to start. But I fully agree with you. If someone is able to start it, it's just as effective as the other medications. It does not have, and I'm not a researcher, and I'm not going to pretend to be an expert on the data behind them, but my understanding is it does not have the proven safety profile of buprenorphine and methadone.
What do you mean by that?
Oh, just the research behind methadone, which goes back, to the 60s, and buprenorphine, which is, since we've been it's been available to be prescribed in the U.S. since the early 2000s. So these are medications have been around a long time, and there's just more experience with them. There's a stronger, more robust research background. But certainly don't hear me dissing naltrexone. I think it's a great medication. Patients that can start it, it's a great option. You didn't mention this, John, but I know you're well aware. Of course, it also really helps with cravings for alcohol. So it's a really nice intervention for someone that can start it that both has a alcohol use disorder and an opioid use disorder.
Just backing up a little bit, in 2004, we pioneered the use of buprenorphine here at McShin. And back then, our protocol, because we didn't think of it, it wasn't really promoted or marketed as a long-term product. It was usually, we used it primarily to get somebody through the detox period. So that 5-6 days, we were detoxing folks, and they were fairly pain-free at the end of 5 days. We do a quick step down, and we would contain them, for another week or two minimum, and then they would start taking the pill, the naltrexone, and that was a beautiful system of care back then before we have all this new evidence that's come up since then. But the thing is this, I remember when I got clean in 1982, for example, I took Antabuse every day for 10 months straight.
Yeah, I was just getting ready to bring that up.
And that was a big drug, alcohol, for me. Mm-hmm. And that did prevent me. But more important, it took away my reservation. See, opiate people especially, they got that deep-rooted brain reservation. Yeah. And so do alcohol addicts, And any tool you can use to eliminate a reservation, that's why the naltrexone is such a good reservation. Vivitrol is such a good reservation. It's like, okay, I'm committed. Boom, boom, boom. But nowadays, you move forward 19 years, and it's just so quick to get somebody on the buprenorphine regimen. Okay, fine. We're not even going to think short term. We're not even thinking a jump, which brings up a jump problem down the road. However, a good jumping opportunity, big incarceration population. Okay, you're locked up for 9 months, 6 months. You're off of everything. I think that's a great time to introduce injectable naltrexone when these guys get out. You make a commitment, daily affirmation, you get this shot, you're good for 30 days, but you got to run the connection and community to find a different purpose than going back to drug use. So, I do bring that conventional wisdom of long-term recovery to the use of these medications. But there's always that connection to community, recovering community that's so vital. However, I'm talking about addiction. But I think a lot of these folks are what they call, what do they call it? You're either an addict or you're an abuser, one of the two. But you can abuse a substance and not really have the disease of addiction. Yeah. And a lot of these opiate guys, that's that one drug, man. That's the one that gets them. And fentanyl is the game changer out there. It's a death sentence to be an opiate addict now. So whatever it takes to keep you off of fentanyl, that's first and foremost, most important thing. And if that's buprenorphine, opioid use disorder replacement medication, you better pay attention to your doctor. Get your head right as quick as possible, and then make some connection to some long-term thinking people if that's applicable.
I just want to highlight what John said there, because I know from knowing John that is what you believe. You said the most important thing, particularly around fentanyl, which is killing so many people, is you do what it takes to get off of illicit fentanyl, whatever that is. If it means walking into a methadone clinic using methadone, that is the answer. If it means using buprenorphine, that's great. If it means moving into a place where you don't have access to it, that's what it means. Whatever it takes to get off of fentanyl is the key thing that we need to focus on. And of course, if someone is using fentanyl, making sure that they have harm reduction measures, safe supplies, access to nasal naloxone, overdose reversal medication.
Never use alone. Always have naloxone on hand. Stuff like that. I mean, we got so much ground to make up in the prevention world.
Yeah. Well, I think a point that I want to kind of put to y'all too, because when you talk about the jump, because to me personally, I mean, and I've been on all these medications that y'all are talking about. I've been on, right? You know, back in 2002, you said McShin pioneered it. I went and seen. I don't want to promote the doctor, but it was a doctor.
We weren't the first one.
Yeah, no. But reason why I'm saying this is because I've got experience with it. Like, in the first thing that back in the day before it became that pill and that tab, it was actually something you broke open, you put a needle in, you pulled it out, and you injected it. That was like the first form of it. And this guy, Dr. Bright, used to be the one who spearheaded it, right? And so I was on this stuff. So I experienced being on this medication, you know, and I think about like Vivitrol. And then I think about the what's the non-brand name? Because I don't want to promote nothing. Buprenorphine, right? So alcohol, because alcohol is like, to me, is like the worst drug there is. It's worse than fentanyl, right? You know, that's just my personal opinion, right? So it's not a jump, right? So when people are coming off alcohol, they detox off alcohol, right? And then it's real quick, here, take some Antabuse. It's not that jump you're talking about. And so what sparks that jump that you brought up, that John had brought up, is the fact that it's not like a detox. It's like it becomes like a long-term thing. It's like, here, get on this medication.
You can't take Antabuse. You got to be off alcohol for 2 weeks. And opiates, you need to be off for 2 weeks to get naloxone.
Exactly.
So
that's the point.
But they're the brain. I don't know if you could ever measure the amount of craving, who's got a more severe craving or whatnot. But off the drug, whether it's alcohol or opiates, it's you know, that 2 week period. I would guess it'd be the same.
The time frame is not what I'm talking about. What I'm saying is, with alcohol, I guess the difference that I see is majority of it's a detox, right? They detox off alcohol, and then they'll go and they'll wait the 2 weeks and they'll get on Antabuse, right? And then you got to make sure they take it, or they'll get on the Vivitrol, right? With opiate users, a lot of times it's not. They don't do the detox. They get on it for a long period. Like, they're on a longer period.
Well, if you're putting on buprenorphine, that makes that jump hard.
Exactly. Yeah. And so that kind of, you know, I think that's what emphasizes that jump that you're talking about.
But just for the record, for detox purposes, alcohol is a longer detox.
Than
opiate detox.
Yeah, definitely.
Yeah, let me just jump in there, because I think although we had planned to focus on opioid use disorder, alcohol use disorder is just a very important topic. I think about, the picture that stands out in my head is, did you guys watch Dope Sick on Hulu? Yeah. There was this scene where Michael Crichton's character is in a rehab facility, and he's really struggling, and he has an opioid use disorder, and he's talking with other men there, and they'd really just lumped opioid use disorder and alcohol use disorder together, both 12-step programming, residential treatment. It works for both. But I think what that scene highlighted was, he said, gosh, all these guys are trying to get off of alcohol. I'm trying to get off opioids. And those two things are not the same. You know, the way I think about it is, for alcohol use disorder, medications play maybe like a 20% role. Lots of people get off alcohol and never use medications. Most people actually who recover from an alcohol use disorder never use medications. 12-step programming, behavioral health interventions are the mainstay of treatment, although certainly some people benefit from medications, as John did. And Antabuse, or disulfiram is the generic name, actually has, although there are examples where it has helped people, it's never actually been proven to help people get off of alcohol. We think probably because people just stopped taking it. But naltrexone has been proven to help people get off of alcohol. But I digress.
With the cravings, that's the craving piece that naltrexone does with the alcohol.
That's the experience that patients report, both with opioid use disorder and alcohol. The patients that benefit from naltrexone will tell me, you know what, I'm not thinking about it the same way as I used to. I can get through the day and not be infatuated with thinking about getting a drink or using opioids.
Me and Beth Macy, the writer of Dope Sick,
Right.
She was sitting in this room.
Oh gosh,
we had a
she's
lengthy
wonderful.
conversation about difference between opiate use disorder and alcohol.
Okay.
And I agreed 100%.
Yeah.
You're on point. And for an old time 12-stepper, abstinent based 12-stepper, who for 41 years has preached, a drug is a drug is a drug.
Right.
I'm here to tell you that it's different between that opioid use disorder and alcohol use disorder, 100%. Now, but with that, there's a couple caveats in there. We all got to do the same thing to recover, and that is not use. But it's a different thinking on these drugs. But I do have a slight resentment toward naloxone being used for alcohol use disorder, and that's the fact that when you take Antabuse, and if you drink on it, you're going to puke your guts out.
Get
and go
sick.
To the emergency room.
Yeah.
You can still drink on the other stuff, but
Did you ever experience that, John?
No, I never did. I didn't want to test it. These Marines were drinking on it all around me.
When you seen them getting sick.
Oh my God! I said I don't want to do that. But the thing, it's a report where naloxone came in. It's a craving reducer for substances for sure, because it's a part of the brain that reduces cravings. And there was a 40% report in there a few years back that it does, alcoholics can take that, and it does help them. So that's all legit. I just want to say those few things, but I do agree that opiate use disorder, and the thing is, see, you can relapse on alcohol, and it's bad. 90% of the time, it's going to be something stupid you're going to do. A few percent of the time, there might be another DUI, you kill somebody or whatever. But opiate, to me, if you relapse on fentanyl, you're playing Russian roulette with a 45. That can be a death sentence. It's a high rate of death sentence. We've seen them.
See it. I mean, I agree. It definitely might be a higher rate, but I mean, in this again, is my personal opinion. People have been dying from substance use for a long time, especially opiate use. It's just it hit a certain demographic of people, so now it got put out more into the world. And that's my personal opinion on it. I agree, fentanyl will kill you quicker, but there's no lying that people have been dying from this for a long time.
Well, here's another thing. For the first time in the history of our drug supply, we have unregulated content in our drug supply. The alcohol supply, manufacturer made, what's in it. It's going to be the same cut every time you drink 151. Even when OxyContins were out there, manufacturer made, you knew what was in the pill. The problem now is our drug supply is completely poisoned. You don't know
what's in it.
You can buy a bag of 5 pills off the street, and 2 of those pills will have a lethal dose, and you're dead. And that's a big problem.
Have you, Doc? Have you heard of fentanyl getting through the blocker?
Yeah, can I just go back to what you said around people dying from opioids? Because, I know your heart in this and how passionate you are about it. But, from my perspective, knowing the tools that we have and the impact that people dying from opioids is having, the reality is that no one should die from using opioids. It is 100% preventable. If we had a robust and we have all the tools that we need to solve it. There's just so many old people, young people dying that should just never die. And it should just break all of our hearts. And I hope that it breaks a lot of people's hearts, because all of these people that have died should be alive based on the tools that we know we have to intervene.
Yeah, definitely.
I think, let's talk about a solution here for a minute before we run out of time. See, I think every emergency room in Virginia should have a opiate use disorder protocol. Anybody comes in there can get access right away, not only to buprenorphine, but access to the peer supports and the medical and clinical support they're going to need. years ago, I tried to talk to General Assembly, and look, why don't at minimum you put a mobile trailer outside of all these hospitals, because 10, 15 years ago, there was a lot of drug seekers going into the emergency room.
Yeah.
And send them out to the trailer and have a Suboxone or a buprenorphine doctor on hand, have a peer on hand, have connection on hand, and we solve a lot of problems. And I am a big fan of community engagement, community workers, health brigade out in the community. You need to be on buprenorphine today, we'll get you on it today. You know, anything to keep you away from that next potential deadly hit, as well as while we continuing to support the black market. You know what I mean? And I'm a fan of methadone too. You know, mobile methadone clinics should be in our communities where people, Jones, and they can get it, right away. And then educate them on the difference between methadone and buprenorphine, and make that little jump when the time comes, or set up a jump system out there for these guys. But destigmatize it too. We're teaching our kids in 6th grade, if you ever become an addict, that's the worst thing that can ever happen to you. You're going to hell, So obviously, here we are in 2023. If you break a leg, you go to the ER. If you get appendicitis, you go to the ER. If you feeling faint, you go to the ER. But God forbid you go to the ER if addiction is your problem, if opiate use disorder is your problem. And when you go there, chance 9 out of 10 you're gonna get treated. Now it's getting a little better. There are some changes being taken place, but not near enough, quick enough.
Yeah, let me just highlight a couple of things you said there, John, because I think they're so important. I think locally and across the country, I think a lot of leaders in the emergency medicine space have really embraced this. I know locally that's the case, and so I know that in Virginia, nearly every emergency department that someone goes into, if they've just looking for a place to get help, if they have overdosed, they should be able to ask for appropriate treatment for opioid use disorder, which for most people would be either starting buprenorphine in the emergency department or going home with the prescription for it. And that's a reason. If, say, you're listening to this and you have a family member or you are trying to think about how do I get help, it's absolutely reasonable to go into emergency department, say I have an opioid use disorder, and ask for help. And part of having an opioid use disorder is just navigating a system where you'll hit roadblocks, and knowing how to advocate for yourself and saying, hey, I know that you don't want to give me a prescription for buprenorphine. Is there someone else that would? Because it's worked for me in the past. I want to try it. Can you help me connect with treatment?
And that's crazy right there, because what if you say, hey, I know you don't treat broken legs in this hospital. Can you refer to me to somebody that treats a broken leg? See, this is where the General Assembly comes in. It should be mandated that if they walk in there and ask for that, they're going to get what they ask for.
And actually, it is. It's opioid use disorder is protected by the Americans with Disabilities Act, and so it is not legal to deny someone access to medically appropriate treatment.
Well, we got to get on that, because that ain't reality. I mean, it might be true, but half the hospitals ain't.
And let me highlight one more thing around this, because for a while a barrier to treating people with a buprenorphine product was this X waiver, meaning a licensed medical provider needed to take a special application to be able to prescribe buprenorphine, and that's gone away as with recent legislation.
So any doctor can prescribe it.
Anyone with a DEA registration, which is
6-hour class or whatever it is.
You actually don't even need to take the class to prescribe it. There are actually some educational requirements, but that's for everyone, regardless of whether they prescribe buprenorphine or not now. And this is targeted, not to medical professionals, but all medical professionals across the country now are required to take an 8-hour training on opioid use disorder. But
that's a good hit. Didn't used to be that.
Yeah, but let me just highlight any nurse practitioner, physician assistant, physician who has a DEA license, it's legal for them to prescribe buprenorphine for an opioid use disorder now, which is terrific. And patients should feel comfortable advocating for themselves if that's something that they need. Politely asking, "Is there a way I can get it here today?" can I walk out with the prescription?
You're a doctor. What do you think the most immediate needed changes need to take place?
I think that's a really interesting question because people always get down to funding as like, sure, we have all these great ideas, but is there money to do it? And I think that my perspective is in the state of Virginia right now, which has expanded Medicaid, which has been a huge source of access to treatment for opioid use.
That back right now.
I think there was a different subject. Yeah, different subject. I think compared to where we were before Medicaid expansion, we're in a much stronger place. More people have access to treatment.
Black and white from 10 years ago.
And then combined with, shout out to the people at Virginia Medicaid who have worked so hard on the arts program. I just friends there, they just pour their lives into making sure that patients get access to appropriate treatment. I can't say enough about them. And so that's one funding source, is access to Medicaid in the state of Virginia. And the other one, of course, is all this funding that's come from these lawsuits. Virginia now has the Opioid Abatement Authority, and it's a huge source of funding. So people in the past have said, sure, that's great, but there's no money to do it. But now in Virginia, we're in the situation where there is money to do it. It takes leaders at the local level deciding, hey, how can we access this money? How can we use it appropriately in an evidence-based way? And one of the best interventions is access to treatment in emergency departments or bridge programming. You mentioned mobile methadone, mobile treatment, telehealth treatment is just one of the. You have other opinions, I know, on the opioid.
I just want to touch on that Opioid Abatement Authority for 1 minute.
Yeah.
I'll be honest with you. I'm following the money, okay?
Yeah.
It ain't looking good right now.
Yeah.
I would be of the opinion, you know what? Let every one of those dollars go straight to their local hospitals all across Virginia and use it for opioid use disorder intervention, to include buprenorphine and inducing. And I think, that's, to me, it's so simple. It's such a no-brainer because as it stands now, the majority of that funding is going to end up in these agencies' employment fund, hiring people to do things. And I know they're supposed to have X amount of those dollars. They're going to have to show where it actually went to a drug going to somebody seeking recovery, but I don't think it's going to end up like that.
Well, I'm hopeful that enough of it will.
Oh, I'm hopeful too.
So, and I'd encourage anyone listening to this just to say, hey, in my local area, where's that money going? We haven't gotten to the criminal justice system yet. I don't know how much time we have left, but I think that's
time in the world.
That's
Jesse's pretty stingy with time.
Yeah, we got about 10. We're gonna get into that if you wanted to. I just want I do want to say for all the viewers out there, because and y'all talked about it earlier, there's no cookie cutter way to recover, and that's from opiate use disorder as well. So you don't have to go get on one of these medications that we're talking about here. There's other ways to do it. So I guess I differ in view with both of y'all, as in, and I don't, maybe y'all can correct me for what y'all were saying. So I agree the emergency room should have a CPRS there, or should have some type of protocol there, but the protocol should be more than just, here, let's give you some medication. There should be more in the protocol there.
I'm saying that's the minimum they ought to offer.
Okay. All right. I was confused because both of y'all were like kind of saying, hey, the protocol should be, let's get them on buprenorphine. It doesn't have to be that for that.
Absolutely. Every patient is an individual. Their treatment needs to be individualized. The reason why the emergency department access to buprenorphine, which within the medical community is called bridge programming, what that means is that the emergency department serves as a bridge to more permanent treatment. So most patients with an opioid use disorder should have access to buprenorphine. That's for a variety of reasons, that medication has clinical benefits over the other two. And so bridge programming traditionally means in Virginia and across the country that someone shows up into the emergency department, they assess if it can be started. If not, they're given a prescription. And the reason it's so important is we know that people who get access to medical treatment through the emergency department are twice as likely to show up into an outpatient treatment as people that are treated without it. Someone, even just given nasal naloxone or given, historically, I think the best patients would get is getting a list of local treatment options. And
let me ask you a question, Doc. Before, going back 15 years ago, we did use buprenorphine more or less as a detox protocol. Yep. Do you think most of the buprenorphine providers are even talking about a 5-day or 7-day detox and try recovery, or is it more like, let's just look for a 6-month exit ramp plan or something like that?
Yeah, that's a great question. Most treatment providers, including myself, should take an individualized treatment approach. So if I have someone that shows up in my office and says, hey, I don't want to take long-term buprenorphine, just help me get through withdrawal, I would say, great. I want to help you meet your goals. You don't even have to take buprenorphine, but let's make sure that you have Narcan available and that you're coming in next week and we can talk about how it's actually going. Because like you said earlier, John, you said the goal is whatever it takes to get people off of fentanyl. We all know examples of people that stopped using, didn't use medication. Great. But when we look at the population as a whole, we know that for the vast majority of people that does not work. And because it does not work, people are dead. Lots and lots of people are dead, people we care about. So we need to say, hey, we're going to meet your goal, patient. We're going to work with you, but just come back and touch base with me in a week. If it's not working, let's do something that will work. Let's not pretend like we know what the answer is before we've tried it.
So there's really no set time. It's kind of individually based. Then is that kind of the thought process with?
But do y'all still do a detox though? If they say, "Look, I just want a 5-day detox," you step down buprenorphine.
Absolutely.
Do that.
Yeah,
All right, that's good to know.
We would do that and. Just try and get the patient. One of the most important goals of outpatient treatment is getting patients to stay engaged. So we don't want people to leave if it's not going well. We want to know it's not going well because we've got solutions. We can, connect people to all sorts of resources to help them stay off of fentanyl and stay alive.
So talking about that bridge program, let's kind of like put that in perspective with the Department of Corrections or the jails.
Yeah.
So like the bridge program, is for the emergency room and helping individuals with some services if they come into the ER. So these individuals that get incarcerated, what are our thoughts on how we should serve them with the medication assisted treatment, or MOUD? Sorry.
You're doing great, Jesse.
Fast learner.
Do you want to go first, Jesse?
Well, I just think
John?
any opiate addict that does time, that's getting ready to get out on the streets, even drug court graduates, that injectable muscular naloxone should be, I would like to see 90% of the people accept that and realize the value of that and do, that should be goal one, I think. And then educate these people how important it is to get your thinking changed and that connection to services, whether it be an outpatient program, a clinician, or some strong social support community. If you're going back to a rural area, there's no good social support communities, but you have a clinician, an outpatient. I just think that you've got to educate these guys incarcerated because they all got their own way of thinking. I'm going to get out. I'm going to do this and this. But if you have an opiate use disorder, chances are good you're going to get on top of some fentanyl within 30 days, a week, or whatever the number is, usually within days. So I think that injectable naloxone would be critical, and connection to community, connection to clinicians would be critical, but they got to get that education while they're on the inside. And that, I think, is a shortcoming of the criminal justice system. They're not educating people.
So you think more of the naloxone approach than the buprenorphine approach?
If they want. If they say, yeah, I do want to stay off, but a lot of them don't. If they know, look, I know I'm going to use and I want to get buprenorphine, fine. Set it up. Get it done.
Yeah. I I do some work in the past and still with the Department of Corrections, kind of helping them with stuff because I was in prison and in jails. And one of the most widely abused things in the Department of Corrections is the buprenorphine. Like they have a lot of trouble with it. I don't,
Well, that injectable one will take care of that.
Gosh, you got me on my soapbox now, Jesse. I got it. I think I hear John's passion for this. I think when people are incarcerated, when they're leaving incarceration, we know that is by far the highest risk people of dying.
Right when they're getting out.
I think engagement to treatment is the key. It's not choosing what medication, it's treating that person as the individual they are and deciding what's best for them and letting them have a say in their own medical decisions. We shouldn't be telling people one thing's better than another because the reality is none of these three medications is better than the other. They are all great tools to help people not die and also to give people the opportunity to do the things John's so passionate about, get their life back together. People need with opioid use disorder the vast majority of them need the support of a medication so that the parts of their brain that they need to use to get their life back together are not distracted by constant cravings and symptoms and withdrawal.
But I also think they should be able to do it while incarcerated too if they want.
Well, that's what he's saying. He's agreeing with that. He's just saying there shouldn't be one specific one, right, Doc?
I was fixed on the exit plan, not so much the stay plan.
Okay.
Because it's a force to think they're going to fund that on a stay plan, but they might fund it on an exit plan. But if funding were available, I think the individual should have access to it while incarcerated.
They have it now. The department.
They can serve maybe 1% of the population with the existing funds.
Well, I just know they're doing it in the jails and the Department of Corrections.
They're all test pilots. It's all on a minimal basis.
I think, gosh, this is such an important topic, and I think legally incarcerated individuals deserve access to quality medical care. We cannot legally deny people access to medical care for any condition. And so it's illegal to have someone with an opioid use disorder who's incarcerated and to not give them access to treatment. We all know folks who have been on methadone and get incarcerated and lose access to it. And it'd be one thing if jails and prisons actually didn't have opioids in them. But you guys have heard the stories. There's no way all of these people who have been incarcerated are telling the exact same untruth over and over. Like the reality is that jails and prisons are absolutely full of buprenorphine products. Yeah. They're full of fentanyl. We've met people who have been incarcerated for decades and been on heroin the whole time. So the idea that there's not drugs in jails and prisons is just clearly a fallacy. And Jesse, you mentioned, gosh, one of the most abused things is buprenorphine. I think the best analogy for opioid use disorder is diabetes mellitus. I spent years treating people with insulin and medications for their diabetes. And you think about a diabetic patient who was incarcerated, needed insulin, who was denied access to insulin. They're going through the worst complications of diabetes, and they find a way to get insulin smuggled in. Mm-hmm. Like, that's not abuse. That's treating their diabetes. And that is the same for this extremely safe medication, buprenorphine. When people who are incarcerated are denied access to treatment for it and they find a way to get it, that's patients treating themselves in a system that is denying them access to standard of care medical treatment. So
that's good. I love that analogy, but I definitely would differ in like just because being incarcerated, there's people that will use buprenorphine not because of opiate use disorder, but because they want to feel the euphoric feeling from using it.
Yeah, absolutely. I respect that perspective on it, and I don't have that personal experience with it like you have.
Yeah, but I always compare the illness, whether it's substance use disorder or if we're individualizing it to opiate use disorder to diabetes, and there needs to be needs to be treated. And diabetes isn't just treated with insulin; it's treated with all kinds of different ways, right?
Everyone with diabetes is an individual.
Yes,
There-
it's just
there's
like
different things that work for them. You know, you meet that patient where they are, figure out which option is best for them. Same way as for an opioid use disorder. What's your disease like? What do you care about? What are your values? What are your goals? Let's figure out which medicine or no medicine is going to work for you. And let's not pretend like we know what's going to happen next week. Let's follow up and see how it's going.
Yeah, definitely.
You know, imagine if the state of Virginia had a diabetes insulin situation where all these jails and prisons, the scenario Doc just spoke of, in our communities, kids are going to the ER and diabetic
And couldn't get it.
and couldn't get it. What do you think the General Assembly would do with that extra $500 million?
Oh, they'd fix it quick, right?
They'd probably throw it all out, but because of the stigma associated with addiction.
Yeah, and it's so, and man, that stigma piece and what both y'all, it's just so hard to maneuver through that. It really is the stigma, and I guess like if I worked as a CO or was running a prison, like maneuvering through who legitimately needs this, right? Really legitimately needs it. Then you got the population over here who don't and who are abusing it and taking advantage of it, and so it's really hard for them in that system to kind of maneuver through that.
Yeah, I agree. There's some complexity that sometimes folks like me don't appreciate. I do think, from my perspective, though, there is so much work to do. Let's not pretend like we're going to get it perfect on the first step, but we need to be taking active steps. If you're listening to this and you're in a community, do you know if people with opioid use disorder in your local jail or the prisons nearby have access to treatment? And if not, can you ask the sheriff about that? Can you ask other elected officials, hey, if half the people in there or 40% are national estimates of people who are incarcerated, like how are people in my community being affected by this? Because when those folks get out, gosh, we've all seen it so many times. Jesse, this is your story. Gosh, look at the impact that you're having. I don't know all the details of how you got better, but you got better and you're having a huge impact. And, let's not pretend we know where you're going to be in 5 or 10 years either. But so many people who are incarcerated could get out, be contributing to their families, be in the workplace, be contributing to their communities. These are extremely capable, valuable people who are incarcerated. And if we give them access to the tools they need to get their life back, gosh, they'll have such a big impact.
Yeah. Doc, what's funny is we're in over 500 jails and prisons. So somebody probably out there is listening to this, and they're going to go to their warden and be like, "Look,
by law, you got to give me this." And that's an unfunded mandate, man.
And then they might try to ban our podcast from being in there. I'm just playing. They're not going to do that.
We mentioned the Americans with Disabilities Act earlier. Most jails and prisons do have an ADA compliance officer, and that's what I've encouraged patients to do is find out who the ADA compliance officer is and put it in writing, put in a formal complaint, say hey, we should have access to treatment here.
And they're going to set that appointment up 3 weeks after their release date.
Oh man, I had when I was in prison, I tore my knee, my ACL, my MCL, and they never gave me surgery. I kept filing grievances, and they kept putting it off until I got released.
Yeah, and that's not okay.
Yeah,
and just to put in a plug, because we keep on bringing up funding, the state of California, they applied for a federal waiver. I believe the Medicaid waiver is 1115.
So the inmates get Medicaid while they're locked out.
That's right. They can use a federal funding system to get access to addiction treatment. So, we talk about the steps we need to take.
If you're pre-adjudicated in Virginia jail, you're supposed to have access to
Yeah, I'm pretty sure they were doing that here in Virginia. They were allowing them.
They're trying, but it's so hard for these individual jails to comply. But
I know the Department of Corrections was the state
they're already
system.
adjudicated in DOC.
Yeah.
But when you're sitting in jail waiting on trial, that's called pre-adjudicated. Your Medicaid should still be kicked in.
Be allowed to use it. Yeah, I see what you're saying.
And setting that houses incarcerated individuals could use that funding source to get those people access to treatment, as opposed to having to pay.
Do that.
So talk about something you could ask your elected official, like, hey, what keeps us from applying for the 1115 waiver? Can we support the folks at Medicaid who
send me that email, and I'll actually look for a member to champion that this upcoming General Assembly, because that's a great cause right there.
Good. Well, we've been going strong here. It's already been over an hour. We're getting ready to close, but I wanted to see if y'all had any final thoughts. John, anything?
Look, man, if fentanyl is your problem, you chase some sort of help as you would your fentanyl, because it's just a matter of time before you die. And don't put that on hold. And I know you may not find the help you're looking for the first place you try, but just like if you can't find your drug dealer the first place you try another one. You try another one, because the doc's he's on point. It's speckled, but there are a lot of compassionate points of entry into some sort of help. But you got to try to find it. It may not come to you.
Yeah. All right. Thank you, John. What about you, Doc?
Oh, just really appreciate you, John and Jesse, having me on, and Steve, thank you.
Thank you.
The work that you all do is just so valuable to our community, and anyone listening, just know, like, if you've got a family member that's dealing with this, or you're dealing with a substance use disorder, I hope you hear that you are incredibly valuable and loved, and your life matters a lot, and it's worth continuing to fight hard and connecting with people who will help you get there.
Spoken like a true doctor gentleman. Right?
Yeah. I was gonna say, John. John's a visionary, and he's been doing this for a while, and I feel like we got a visionary on our hands here with you, Doc. Y'all two sharp guys. I hope y'all, listen to everything that's been brought up here, and do what you got to do for your recovery, and make sure you understand that there's no cookie cutter approach to this. So it's okay to seek some of the help that the doctor and John were talking about here. All right. That's it, y'all. Peace.
More later.